Welcome to the 4sight Health Roundup podcast, 4sight Health's podcast series for healthcare revolutionaries. Outcomes matter, customers count, and value rules. Hello again, everyone. This is Dave Burda, news editor at 4sight Health. It is Thursday, March 21st. We're 2 days into spring, and it might snow today. You gotta love it. But there's not much love lately for the Medicare Advantage program. So little that some big brains are thinking about the program's future. One big brain is Chartis, the healthcare management consulting firm. Earlier this month, Chartis released an analysis of the Medicare Advantage market. It said that the MA market is facing mounting headwinds and that the program is at an inflection point. Chartis said MA enrollment grew by 5.4% this year, but that's down from a record 9.4% increase in 2023. Another big brain is McKinsey, which needs no introduction. A week after Chartis released its report, McKinsey released a paper on the future of Medicare Advantage. McKinsey said the MA program is undergoing its biggest shifts in more than 2 decades. The paper said MA plans will face downward pressure on revenue and, as a result, put pressure on them to contain costs. An aging population, a tougher star rating program, and new health equity quality measures also are headed their way. What do we think is ahead for Medicare Advantage? You can find out by listening to this rebroadcast of our February 15th episode, Rethinking Medicare Advantage. Enjoy. Is the bloom off the rose for Medicare Advantage? That's what we're going to talk about on today's show with Dave Johnson, founder and CEO of 4sight Health, and Julie Murchinson, partner at Transformation Capital. Hi, Dave. Hi, Julie. How are you guys doing this morning? Dave?
Well, baseball means spring, and that makes me very happy.
Yeah, you're a big baseball fan. Thanks, Dave. Julie, how are you?
Well, my household is definitely still licking its wounds from the Super Bowl, so I can't say that it's great, but I enjoyed the Taylor Travis coverage. That was fun.
If your team loses, it only makes you stronger. That's what I say to myself.
Tell yourself.
Let's talk about Medicare Advantage. Certainly been in the news a lot these past few weeks. Let me run down a few of the big events, and then I'm going to ask you what they mean for the market. In January, Cigna agreed to sell its Medicare Advantage business to HCSC, the Big Blues parent, for more than $3 billion. On the same day in January, CMS proposed a slight cut to the base rate paid to Medicare Advantage plans for 2025. That would be before CMS adjusts the rate for enrollee risk. Earlier this month, Cano Health, a primary care provider, filed for bankruptcy. Its main line of business was Medicare Advantage. Also, earlier this month, CMS sent a memo to Medicare Advantage plans telling them that they can't use algorithms or artificial intelligence to make enrollee coverage determinations. You have a reported rash of hospitals and health systems terminating their payer contracts with Medicare Advantage plans. And I just read before we got on this morning that private equity investment in Medicare Advantage plans is dropping. Dave, as Vince Lombardi said, what the hell's going on out there? What do you think of the slight pay cut and the contract terminations, and what is the market saying?
I'll start with your last question first. What's the market saying? 2 things. You can run, but you cannot hide. And secondly, accountability is a bitch. David Corgnani, the Cigna CEO, basically said as much at his press conference when they announced the sale of their MA business to HCSC, when he said the business wasn't worth the money they needed to invest to maintain it. Honestly, the writing has been on the wall with MA for quite a while. 2 events sort of a year and a half ago were the early indicators. The first was the 2-part series by Don Berwick and Rick Gelfand in Health Affairs, where they basically said payers were ripping off the government on Medicare Advantage, gaming the risk adjustment factors for their own benefit. And then the second was, and I think this is a real telling indicator, partly of what's going on now, was the battle between Mayo Clinic and United when Mayo announced that they would no longer provide care other than emergency care to out-of-network United Healthcare Group MA members, and there are a lot of them. And I don't know if you remember that, but it settled pretty quickly. I don't think United Mayo would cancel the contract, and they came back to the table pretty quickly. So this fault line between private administration of government-funded benefits is there, and it's real, and it's starting to manifest itself in the marketplace today. Stepping back, and I'll get your question about what do I think about the government's payment adjustment. You know, Dave, you and I are real fans of Mad Magazine, Jaffe, Alfred E. Newman, that old cartoon, What Me Worry.
Right.
I think, snappy answers to stupid questions. Anyway, I think part of what's going on here, the payers and providers are basically doing a version of Alfred E. Newman. What, me take risk? In the aggregate, it's not everybody, but in the aggregate, they treat patient risk and the care management it requires like a hot potato. Nobody wants to hold it. And, like you just said, I think with the MA plans, the bloom is off the rose a bit. And, no amount of marketing glitz can make up for a bad product. And so much of what drove MA sales were adding these incremental benefits with virtually no cost. Meanwhile, they're making it all up on the risk adjustment factors. And people are starting to see through that. The providers are back in the game and have figured out, I think, how to force the payers' hands. Meanwhile, the government is tightening up rates as they should do. But all this begs the question of when is this country and its healthcare system actually going to step up to the challenge of managing care for distinct populations? We talk about it all the time. Reminds me when I was in a Peace Corps volunteer in Africa, and I'd never heard so much talk about corruption and what to do about it, and seen it so widely practiced. And we talk about value all the time, and yet so few really practice it. If payers and providers don't proactively embrace active care management and value-based delivery, as I said right at the top, you can run, but you cannot hide, and accountability is a bitch, and that's where we are right now, and it's showing itself in all this market activity related to Medicare Advantage.
Wow. Thanks, Dave. I love Jaffe's snappy answers to stupid questions. And the more I think about it, that could describe what we do every week on this podcast.
We are snappy.
You're snappy and I ask stupid questions.
And I'm snippy today. I'd say I'm snippy today, too.
I can tell. Julie, be careful. Any questions for Dave?
Dave, great observations. Everything that I have read and heard people talking about with these contract cancellations, it just feels to me like there's pain to be spread all around. Who do you think gets hurt the most? Is it the health system, long-term, short-term, long-term, the health plan, or the member?
At least in the short run, per usual, the consumers are going to be the ones that are probably hurt the most. Dave said it at the top of the broadcast, where maybe a few years ago he would have thought about MA, but he's not going that direction now. And so I think consumers are going to see the benefits cut, probably, the natural creep in copays and deductibles, the way that happens, up until we get companies that really partner with consumers to help them manage their real health and healthcare needs. And we've got some of those. Julie, you're investing in some of these companies, but we need them to get bigger and grab a bigger share of the market so that the overall industry embraces these ideas.
Got it, Dave. Thank you. Julie, it's your turn. What do you think of the Cano Health bankruptcy and CMS's AI directive? What do they tell us about what's happening in the market?
Well, I'm going to take us down a little historical path, but if you want to understand Cano Health, you have to start with Leon Medical Centers. Leon was founded in 1996 in Miami, Florida, like our friends at Cano. They provided primary care services, medical centers, transportation, med management, and they did exceedingly well for years and made a lot of money in that business. They frankly did a lot of good for seniors in South Florida. I view Cano, which was, by the way, founded in 2009. By the way, ChenMed also located in Miami, right? A lot of juju here. But I think Cano's providing similar services plus an MA plan. And I look at it as kind of a lookalike, frankly, to Leon Medical Centers. And Cano quickly became a high flyer because of the MA component of what it was doing. And, that caused it to be almost unicorn status. It used that SPAC. Remember we talked about the SPACs to go public? And it should have been able to make plenty of money, just like Leon Medical Center, but the reliance on MA and its plan certainly had an impact. But let's talk about the SPACs. If you remember, the participants themselves that put the SPAC together made a lot of money. And they would often load the companies up with a lot of debt. And it's a very expensive way to go public, as we talked about for a long time. So here's Cano. They go public through a SPAC. Public markets fall apart. And now it's bankrupt. It has more debt. I mean, an obscene amount of debt that it can't service. And let's just look at the stats. As of July of last year, of the 860 SPACs that were issued between 20 and 22, 277 or 32% of those have liquidated. I mean, that's a huge percentage. Double the historical levels before 2020, but that doesn't really matter since SPACs were such a new thing. And separate stat, bankruptcies of healthcare companies have been on the rise, as we know, and they hit a 5-year high last year. So, we're seeing a lot of confluence of issues here. So the story about Cano, I don't know, is it a story about MA and its reliance on MA revenue and the MA adjustments? Sure, I'm sure that's part of it. Is it about the fact that they went IPO through a SPAC and its impact on their model? Or is it just inefficient operating models, which a lot of people say the founding CEO was not the best operator? So, I don't know. This Cano story can't all be blamed on MA. This AI directive, it annoys me. I'll say that just because CMS included the words algorithms and AI in its directive. And it did that because technology is just moving too fast and you can't put a label on these things at the moment, right? But the issue here is not whether sexy AI is doing something wrong. It's that we're automating decisions based on, inferior or incomplete data training models. And we don't have the personalized data we need about the patient in question in all of these automated decisions. So if we think about what the word algorithm is, it's nothing more than an automated rule that a person would have had typed up in their how to do my job manual, 15 or 20 years ago, right? These are blunt rules that are becoming more refined and nuanced with how technology is advancing. But look, comorbidities create decision complexity in those things. Social determinants may not be fully absorbed into the decision intelligence. So here comes Congress and CMS. Senator Warren was way outspoken on this issue. They're forcing insurance companies to prove the reliability on these algorithms and the AI black boxes that they're using in ways that may not be, frankly, appropriate for the sophistication of how these technologies are getting to decisions. So I get the intent, but we're beginning to see cracks in our, federal leadership's understanding of how these technologies work and how to trust them. So, I frankly think this directive is going to be the beginning of a much bigger discussion of how data is used in these kinds of decisions.
Yeah, blunt force trauma. I get it. Thanks, Julie. Dave, any questions for Julie?
Great analysis. What I didn't hear in your answer, Julie, which is probably what motivated the CMS in the directive, is their belief that there's some malintent on the part of payers to, use AI to increase denials. And again, in a pretty blunt way. So I absolutely agree that, having complexity in sort of sifting through and deciding what and what not to pay is probably beyond the reach of most models. They'll keep getting better at it. I do wonder about some level of malintent, and I probably argue on the other side, the providers are getting good enough at this that they're playing the game better, which is sort of forcing the payers to up their game. It's a little like arms control. We need each side to step back from the brink.
Yeah, I didn't want my comments to be construed as supporting the payer side necessarily, because I think you're right. And what I see every day in my role is really the fight over data. Like the arms race is the data race, right? And plans have been trying to get enough clinical data for years to do their job better, or, well, to do their job. And they still don't have enough clinical data. So hence these training models aren't robust enough. So I don't disagree with you. I think there's obviously intent to manage the business for the good of the shareholders, shall we say. But, providers, I would rather see the federal government recognize what some of the foundational issues are that help create a more fair system, because that's really what it should be, trying to help us do. And instead, we have senators making statements about things that they don't really understand. That's my point.
Yeah. Very fair. Very fair.
Thanks, Julie. And I think we all agree there is turmoil in the Medicare Advantage market. And as a soon-to-be beneficiary, I'm very anti-turmoil. So that's my position. I'm back, and it's still March 21st, and it still might snow. We hope you enjoyed the rebroadcast of our February 15th podcast, Rethinking Medicare Advantage. I turned 65 in about a year, and it will be traditional Medicare for me. If you'd like to learn more about the topics we discussed on today's show, please visit our website at 4sighthealth.com. And don't forget to tell a friend about the 4sight Health Roundup podcast. Subscribe now, and don't miss another segment of the best 20 minutes in healthcare. Thanks for listening. I'm Dave Burda for 4sight Health.